Okay. Hello. Good morning. This is Dr. Praveen Chandra from Medanta Medicity Hospital in Gurgaon in India. And along with me is Dr. Abhinav
Hi.
and my other team members looking at the IVAS, OCT, and the cath lab. So here we have a patient who is 75 years of age and had previous bypass surgery and then also had multiple angioplasties in the past, about 3 of them. And I will just show you the angio which has been done today. So can you look at the angio now? So you see that, there are multiple stents being seen in the LAD, LCX, and the LCX is quite long. There are 3-4 stents there, but all are gone. And we see that it is totally occluded circumflex, but the right artery is a huge superdominant and it's tortuous with a big loop in the middle and a very tight lesion which is calcified. So why I'm saying calcified? Because on angio and also a CT was done before this. A CT showed that this is a very heavy calcified artery on the CT and the score was very high. So we plan to do the angio now and we see that yes, that tight lesion is there, which is most likely the culprit leading to unstable angina in this situation. And next please. So we check the same artery in different view, and we see that the main vessel is going into the PLV distribution. PD is also reasonable, but has no major disease. Next slide. Okay. So this is another view. Next. And in here we see that the lima is flowing very nicely. The lima flow is very good, extremely nice, no issue of any stenosis, etc.
Next.
So in view of this, we decided that we have to treat this RCA. But the first question was which guiding catheter. So we decided that we'll take this AL1 guiding catheter because this will give a good support, and also that we will be able to, because we have to take most likely a shockwave therapy here and also intravascular ultrasound.
Previous.
Okay.
Previous.
But it's okay.
RCA loop, sir.
RCA loop we have seen already. Yeah. So this is the loop. Okay. So that is why we are thinking upfront of a good guiding support.
Yes.
And also at the same time, we decided that we should use a guide extension support. Most likely it will be required because you see there is a calcium at that loop area in the middle. And so we took this guide liner, and this is not the guide, this is the guide +2 extended lumen guide extension, EL. And this is 1.43 in the lumen area. And then next slide. And this is in good position now without any compromise of the flow. So we are quite happy with this. And we just thought we will do a pre-dilatation first using a 2 millimeter balloon, so that in case we have to do an IVAS. So this is a 2 millimeter balloon going up to 12 atmospheres. Next slide. Yeah, this is the IVAS now. This is a volcano, solid state. And now you will see the IVAS images. Show the IVAS images, please.
Play it again.
Play it again. Go distally. And this is the distal landing zone, looks quite good. But there is a lesion beyond the bifurcation also. You saw that. And that is tight, calcified. And here also there is reasonable amount of calcium. So here we are. So in this situation, we thought it will be better that we do a good, therapy for this these two lesions which are together. And we have planned to take a 3.5 IVL and then followed by most likely a stent. We will see. We are open to a drug-eluting balloon also, because there is a branch there and we might like to protect it. So we will see. So I'll take the guide extension inside. So this is the guide extension going inside. You see the movement is quite smooth. It's taking a turn there, and it's a big loop. And here, okay. So we are almost in the mid distal part of the RCA, and this seems to be a good position for me. And the pressures are still fine. There is no wedging. So I will take the shockwave balloon now, which is a 3.5. Okay. Okay. So the point of concern here is that when we take these guide extension catheters, we should have a good lumen. So in a 7 French, we have taken, although a 6 French, but it is a extended lumen, 1.4, guide plus 2. So now you see that this is moving easily with some resistance, of course, but I'm going slowly so that it doesn't get pushed out. And very nice. Okay. See, first we'll reach that calcified distal lesion. Okay. Check, please. Okay, I think we are there. Okay, check, please. A little check. I think we are fine. Okay. 1, 2, 3, 4. So we are going up to 4 and on. So we are giving the first set of pulses. And you see at the screen there is some entrainment, but everything is okay. Deflate. Deflate, please. This is a very important artery, so we'll have to be very little careful. Okay. Okay. Pressures are fine. Okay, one more. अभी आपको सिर में टक टक की आवाज आएगी. Don't worry. So we are giving the second set of pulses. Okay. Okay. Deflate. Okay. Give him some breathing time. And vessel is flowing. Okay. One more. 1, 2, 3, 4. Okay. Okay. That's nice. So typically, in this kind of situation, I think most of you will agree that in a calcified lesion like this, the most appropriate therapy will be IVL because of few reasons. One, that it is quite distal. Taking a rota all the way through this tortuous segment may be difficult. The second is that the vessel size is very big. So even if we use a 1.5 rota, it won't make much difference. And then other options are orbital atherectomy, but I don't think, again, it is a good idea to do orbital atherectomy here. So I'll come back. And also, one can use a cutting balloon if required. So I'm trying to pull back. Okay. You see? Okay. Yeah, check, please. Yeah. Okay, fine. Go up. 1, 2, 3, 4. Okay, you see? Okay, go up. So we are giving the second, third. This is now the fourth set. We have done deflate, please. Okay, we will be fine. Don't worry. जब हम बुलाते हैं तब पेन होता है. Okay, go up. 1, 2, 3, 4. 1, 2, 3, 4. Okay.
Negative.
Negative, please. So we'll give some more energy here. Go up. अभी ठीक हो जाएगा. 1, 2, 3, 4, 5. So I have pulled back the guide liner also a little bit, the guide plus 2. Deflate. We'll give some breathing time to him. Okay. Check please. One shot, quick shot to see if the vessel is flowing well. Yeah, it's okay. Okay. Go up. 1, 2, 3, 4. Okay. So we'll finish all the pulses here because we want to give it the maximum deflate. And deflate please. Bus. Okay, okay. So I'm taking this balloon out. So the
NTG.
NTG now. Patient has some chest discomfort, which is understandable because we were doing inflations. And now we will give him some rest. Give some nitro, please. So this is something which we have to keep in mind, that those patients who are very dependent on that vessel's territory. So we have to give them some time for the vessel to flow in between. So here you see the flow is very good. Still we see that there is some residual over there. We can maybe do an IVUS and see. Let us see an IVUS. Do an IVUS. हाँ अभी ठीक हो जाएगा. We are fine. So there are two possibilities. One, we can go straight with a stent, and the second is that we can even do a 4 millimeter balloon, cutting balloon, 410, and then see how it goes. So
Extension.
so I'll put the guide extension again a little bit inside because I'm taking it out in between because there should not be prolonged ischemia. I mean, there is no pressure drop, but still there will be some effect. Yeah. Because of that proximal loop, I'm trying to do this. Yeah. So with this, it goes so easily inside. Yeah. Okay. On. I was. Yeah. So this is the distal, which is fine. And here we can see that there are some cuts here, some fractures, and in this also. So should be fine. I think we'll be able to put a stent straight away. Get me a 3.5 26. So the other option is that we can do a drug-eluting balloon over, but since we see that there is some residual still there, I would take a stent. 3.5 26. And the stent will have to, in the proximal area, go up to 4. So this is, we are taking a 3.5 26. So why, why do you want to take a 3.5 26 and why onyx?
So distally, as the vessel is around 3.5, the lumen area in the IVUS, so better, and it will this onyx will go up to 4.5 and 5.
Okay.
So and the side branch protection in this is very good, as we have seen in our experience.
So this is an open cell design.
Yes.
So we need to take a stent which has an open cell design, and also we have to know in each cath lab that which stent has. And we'd gain that experience, and of course with the data as well, that the side branch protection should be something which should be kept in mind all the time. So the stent goes quite easily with this guide extension. Yeah. So I'll see if we're falling short or something.
Looks like.
Maybe we'll have to change to a 28. 28 or 29. It is
Yes.
slightly short. It's 26 is slightly. I think it's better to take a 30 or a
32.
29.
30,
30,
30,
30 or
30.
29. 30. 30.
Yes, yes.
Yeah. I'll change it to a 30. Because there is a distal plaque, so it was landing into that distal plaque, which we should avoid. And so this is a 3.5 into 30. Should be fine. So this is a same on 3.5 30. Now you'll see again that the movement of the stent in the proximal loop quite smooth with the help of this guide +2. And I'm going a little distal. Okay, check please. Now this is better. Yeah. Take a shot. This is absolutely perfect. Okay. Yeah.
AP view. We can just check in one more view.
Take in one more view. Okay. Epicranial.
Yes.
Looks to be okay. In fact, we can pull a little bit back. Just a fraction of a millimeter. So I'm pulling a little bit back. Okay. This is fine, I think. Check, please. Show me. Is the distal segment okay? Yeah, fine. Okay. Check again. Yeah. Go up. 1, 2, 3, 4. So this is a 3.5, 30. 2, 4, 6, 8, 9, 10. So you saw that the lesion gave way quite easily without much problems. And at 10, it is 3.35. And distally, I really don't want to go too much because it is between 3.4 or so. The distal vessel landing zone is about that. So I'll just deflate it. Deflate, please. Chest pain will be there because we are putting the stent. Okay. 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 So we have to be a little careful about the distal landing zone, especially when the vessel size is tapering a little bit. Okay. So with this, we can do a quick check with IVUS. And so why we are doing IVUS? Why not in view more shots? Because that will avoid some contrast, and we will know exactly how much and how we have to post dilate. There's some resistance, but it goes inside. Okay. Okay.
Distally is perfect.
Distally, we are fine. As you can see, there are some distal calcific spots, but this is fine. I think it is okay. You can see that distally the stent is well expanded, and we come into the mid segment. Here also the lumen looks good. Okay. And also at the bifurcation. Here we have to do with the 4, I think. Yeah, stop. Show me the distal and the proximal. Can we review the IVUS again to see whether we need any post dilatation in the mid segment or just the proximal segment? The distal is fine. Yeah. Give some nitro.
PCT.
The lumen area looks good. Can you check the lumen area here? Stop, yeah. The minimum one. Go a little bit. Yeah, here.
NTG.
About 6.1, which is quite good. Okay. Yeah. So proximally, the stent has to be opposed better at the margin. And I think 4 millimeters should be 4.8. 4.8 or 4.10. Yeah, here we have a 4.12. Okay, we can take a 4.12. Yeah. 4.12. So I'm taking a 4 millimeter balloon for proximal edge. So this is a 4 into 12, non-compliant. And so this case was a calcification in the in the distal part of this at the bifurcation with the tight lesion. Although this calcification was not very heavy, and some people may say that I could even do it without this, which is fine, but it is always better because this patient had multiple treatments, previous CABG, 3 angioplasties in the past. So we must try to do a good job so that he doesn't come back again quickly.
Zoom.
Yeah. Zoom, please. Okay. Okay, I can pull back. Okay, so do a stent boost on this. Stent boost, please. So this image is visible to them. Yeah.
Yes,
We
it
can
will.
do a stent boost. Do a stent boost. Okay, stent boost.
Stent boost.
ECG is absolutely stable, which means our side branch is doing fine. No chest pain, nothing. So you can see that the position of this balloon is good. And the stent expansion, you can see that we will go more. Okay, go up. 2, 4, 6, 8, 9, 10, 12. Okay, deflate. We'll do a stent boost again. Show stent boost. Yeah, the stent seems to be better expanded. We can go slightly higher pressure because I still see some residual. We can go even further. Go up. 2, 4, 6, 8, 10, 12, 14. Okay. Deflate. So now you can check a little bit. Check, please. Yeah, that's fine. So I think this 4 millimeter dilatation is done. And
NTG.
NTG we have given already. We can do one more final round of IVUS imaging because we do before we finally take out the wire and everything and take the final shot. So we will take a final shot after this imaging. So again, some resistance, but it's going. We are slowly moving ahead. Yeah. Okay. Pull back. I was very well expanded now, and apposition seems to be okay, and no edge dissections. So we will take a final shot. Can you check, please? Let's take a final shot. Yeah, that looks nice. And what about the side branch? The PD is also flowing very well.
Yes.
And overall, I think it's a beautiful result. We don't need to go any further. The stent expansion is okay. And we have done the IVUS also. How much is the cross-sectional area in the proximal and the distal? Yeah, here you can check the minimal area, MLA, 9.9. In this distal RCA, I think has a good overall outcome will be fine. And distally, how much is this? 8.8 square millimeters. So with this, I think in this very heavily medium calcification, and also that there is a side branch and so much tortuosity, we were able to deliver the the shock wave, which was a 3.5 balloon, and a stent which was 3.5, went up
30,
to 30 millimeter long stent, and this was all on a BMW wire. Okay, so I'll take this guide extension gradually, careful. Yeah, okay, and then we must take a shot because sometimes there could be an injury in the proximal segment. Let's take a shot. Okay. 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 This looks nice. So that is done. The loop is now coming back again. Go into the LEO. So we were a little concerned about the calcification and the proximal loop and the calcification distally, but everything went off fine because we had done some planning before, and the use of the CT's images was quite helpful because we knew upfront that this is a patient who will have calcific lesions, and we have to be prepared with the devices which can take care of the calcium. So I'll take the wire out slowly, and I see there is a resistance. As I'm pulling the wire, the guide is going inside. Okay.
Balloon. Two balloon.
So for this, many times what I do is we take a balloon inside so that the guiding doesn't jump too much inside. And because at this stage, sometimes this is a 7 French guide, it can injure the proximal part of the RCA, and then you'll again try to put some stents. So that one has to be careful. Okay, you see, if even the balloon is going with difficulty. Okay, now I am pulling the wire, and the guide is not jumping that much. Okay, so we are back into the middle. Now I'll pull both the things together. Okay, fine. Again, one more shot. Okay. So you can see that now again the loop has come back, but there is no apparent injury or anything. And come back to the RO also. We will check in the RO position. Okay. Yeah, it's okay. So there was some disease also in in that segment, because there was a stent in the middle which was done put some years back, but now everything seems to be all right. So go to Elio, and so we will take this catheter, okay, quickly, and we can now do an angioseal. Yeah, I'll just also demonstrate this angioseal, because in India, not so before doing an angioseal, I have to do a shoot to see whether we have punctured the CFA, not the profunda or something. Because if it is profunda, then we cannot do this. I'll take a shoot. RO caudal. RO. 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 RO caudal. Okay. So I'll take a shot. We are there, right, just above the bifurcation. No problems.
Better in.
And the artery is good size, so we are fine. So this is a 8 French angioceal. Okay. Prepare this. Okay. And now we'll take the wire inside. Okay. Sometimes you can even give some local here, because in a prolonged procedure, the effect of lidocaine goes away after a while. And we'll have to look at the flow. I can see very nice flow here, which means we are in the vessel properly. And now this is the plug, goes inside, and then we have to get 2 clicks. 2 clicks done. So some push and pull. So pushing this small, this blue tube distally, and pulling the whole thing back, so that the coagulation will happen. We'll give it 30 seconds, and that should be done. So this was to emphasize the fact that in patients who have previous history of bypass surgery and multiple interventions, one should start thinking that these patients might be having a calcification, and a CT image is also very important. We should take that into consideration before planning a case like this, because many times on routine angiograms we don't see that much calcium, but when we start doing the procedure, then we are stuck in between. So here you can see that there is no bleeding, nothing, everything is okay. Just that's all. So with this, thank you very much, and we'll see you again at 4:30 today itself, and with another calcification treatment in coronaries. Thank you very much. Okay, all done. Thank you.
Yes, yes. Over. अच्छा होगा, अच्छा होगा, बस अभी बाहर शिफ्ट कर देंगे आप। थोड़ी देर दोबारा ऐसे बिल्कुल आराम से, हल्के हाथ से, हल्के हाथ, बहुत ज्यादा भी नहीं।